Myself Dr. Gunjan, and as you can see, today we'll be discussing the normal menstrual cycle. Now, in our previous series, we studied about the physiology of normal menstrual cycle. Now we'll see the features of this menstrual cycle. Now, what do you mean by menses? It is basically the shedding of the superficial layer of the endometrium. Now, remember we had studied that the endometrium has got a superficial layer and a deep layer, or the zona bassalis. And it is this superficial layer which is shed during menses, and the regeneration of the endometrium, it occurs from the zona bassalis. Again, a very important question that we have already discussed. So shedding of the superficial layer of endometrium is called menses. And how does it occur? We know that in the first half of the cycle there is predominance of estrogen, and under the effect of estrogen there is proliferation of the endometrium. And when the ovulation occurs, then in the second half of the cycle, the predominant hormone is the progesterone, and this progesterone, it supports the endometrium. It basically causes the desterilization of the endometrium. And subsequently, when there is decreased level of progesterone because of the degeneration of the corpus luteum, then because of this decreased progesterone, the support to the endometrium will be lost, and subsequently menstruation occurs. So if you are asked which is the most important hormone needed for menses, it is the progesterone. An important question. But you should remember that this progesterone can only act on an endometrium which is primed with estrogen. So if you are asked that which is the hormone responsible for menses, and in the option you have estrogen plus progesterone, then you should always go for this answer. But if you have been given progesterone, estrogen separately, then the most important hormone is progesterone. Then the most frequent question that a gynecologist is asked is how to postpone the menses or prepone the menses. So with this basic knowledge, we know that if we start the progesterones, then there will be high level of progesterone in the body, and subsequently it will not allow the menses to occur. Only when you stop this progesterone, the level of progesterone goes down, and then the menses will start. So if you're asked the prescription for postponing the menses or preponing the menses, then you should give progesterone. And either you can give norethistron acetate in the dose of 5 mg BD till you want to postpone the menses, or you can give medroxyprogesterone acetate in the dose of 10 mg BD again till the time you want to postpone the menses. And once you stop these drugs, the menses will start in another 2 to 3 days. Then one important thing is that these drugs, they should be started around 3 to 4 days before the expected date of menses. Now, how does the normal menses occur? We have already seen that because of the degeneration of the corpus luteum, there will be decrease in the level of progesterone in the body, and this will lead to the release of metalloproteinase enzymes. And this metalloproteinase enzyme, it causes ischemic necrosis of the endometrium and thereby shedding of the endometrium, leading to the onset of menses. Now we know that progesterone is a smooth muscle relaxant. So if there is decrease in the level of progesterone, it will subsequently lead to vasoconstriction. And in turn, because of this vasoconstriction, there will be release of PGF2 alpha, a prostaglandin which causes increased myometrial contraction, spasm of the uterus, and thereby leading to dysmenorrhea. So you can say that this dysmenorrhea, it is an indirect evidence of ovulation. And this is a very important question, that which is the prostaglandin involved in dysmenorrhea, and it is PGF2 alpha. Now let's see the characteristic of a normal menstrual cycle, and the normal length is around 21 to 35 days. Few studies quote it as 24 to 38 days, but if you remember 21 to 35 days, this is sufficient. And in this, the average length is 28 days. Around 15% of the population have 28 days cycle. Then during the cycle, they bleed for around 4 to 6 days at an average, but if you are asked the range, then it is 2 to 7 days. If it is more than 7 days, then we call it menorrhagia, and if it is less than 2 days, then we call it hypomenorrhea. Now the average blood loss during a menstrual cycle is around 35 ml, and it ranges from 5 to 80 ml. Again, if the bleeding is more than 80 ml, we call it menorrhagia, and if it is less than 5 ml, we again call it hypomenorrhea. So if you are asked the average blood loss, you should always look for option near to 35 ml. Now this was about the features of the normal cycle. Now let us talk about dysmenorrhea, which almost always accompanies the menses. Now what is this dysmenorrhea? The pain during menses. In simple words, you can say the pain during menses is called dysmenorrhea. And it can be either the primary dysmenorrhea or secondary dysmenorrhea. So first let's talk about the primary dysmenorrhea, and as the name suggests, primary. So in this there will be no pelvic pathology, and the pain is because of the prostaglandin PGF2 alpha that causes myometrial contractions, spasm of the uterus, and therefore this is also called spasmodic dysmenorrhea. So primary dysmenorrhea is synonymous with spasmodic dysmenorrhea, and you can get a question either as a primary dysmenorrhea or the features of spasmodic dysmenorrhea. Remember, they are one and the same things. Now the next important feature is that it is seen in the younger age group, and they usually disappear after childbirth. So they are rarely seen in the reproductive age group. And the typical feature of primary dysmenorrhea is that the pain begins few hours before or just after the onset of menses. There will be no pain from beforehand. The pain will start either at the time of menses or few hours before the onset of menses. And it usually subsides after the onset of menses. Once the menses have started, so they will subside in another 12 hours. And they never persist more than 48 hours. Again, a very important feature. They never persist more than 48 hours. So remember all these statements, because you can get question from any of these statements. Now I told you that this primary dysmenorrhea, it is the indirect evidence of ovulation. So the anovulatory cycles, they are painless because in them there will be no PGF2 alpha, no release of PGF2 alpha, because this PGF2 alpha is because of the decreased level of progesterone. Now try to correlate that this primary dysmenorrhea, it is because of the PGF2 alpha, that is in turn released because of the decreased progesterone levels, and that is in turn because of the ovulation. So if there is no ovulation, so there will be no pain. So anovulatory cycles, they are painless cycles. A very important fact. Anovulatory cycles, they are painless cycles. Now this was about primary dysmenorrhea. Now coming to the secondary dysmenorrhea. And as the name suggests, secondary means it is secondary to some pelvic pathology. And these pelvic pathologies, they lead to pelvic congestion and subsequently leading to secondary dysmenorrhea. And what can be the pelvic pathologies? It can be associated with endometriosis, adenomyosis, fibroids, polyps. So secondary to these pathologies, it can lead to pelvic congestion and thereby leading to secondary dysmenorrhea. And this is the reason that secondary dysmenorrhea is also called congestive dysmenorrhea. They are one and the same things. I told you that primary dysmenorrhea, it is also called spasmodic dysmenorrhea, and secondary dysmenorrhea is also called congestive dysmenorrhea. Now this is seen in the reproductive age group. We told that the primary dysmenorrhea, it is rarely seen in the reproductive age group. Now here we talk that secondary dysmenorrhea is seen in the reproductive age group. In this, the pain is present 3 to 5 days before the onset of menses, and they do not subside even with the onset of menses. So a pain which starts to 3 to 5 days before the onset of menses, and they do not subside even with the onset of menses. So they'll continue even after the onset of menses. Now coming to the management, and in case of primary dysmenorrhea, the first treatment, the treatment of choice is NSAIDs, and in this you can give mefenamic acid. These are basically the cyclooxygenase inhibitors, and therefore they will relieve pain. Now another important thing is that if this dysmenorrhea is associated with menorrhagia, then in that case the treatment of choice becomes OCPs, the oral contraceptive pills. And these OCPs, they need to be given for 3 to 6 cycles. And we know that the OCP contains synthetic estrogen and synthetic progesterone, and the estrogen, we know it has a negative feedback action on FSH. Thereby, if you give synthetic estrogen, it will lead to decrease in the levels of FSH and the natural estrogen. And the progesterone component, it has a negative feedback action on the LH, thereby the level of LH will reduce and the progesterone levels decrease, and subsequently it will lead to anovulation. And I have already told you that the anovulatory cycles, they are the painless cycles. So they will relieve the primary dysmenorrhea as well as menorrhagia. But one very important thing is that even in cases of primary dysmenorrhea, if the patient is not relieved even after giving OCPs, then the next choice is laparoscopy. You need to go for laparoscopy to rule out pelvic pathologies. And in this, a very important pelvic pathology that you should keep in mind is endometriosis. So even if the primary dysmenorrhea it is not relieved on giving occipits, then you should go for laparoscopy to make a proper diagnosis. Now coming to secondary dysmenorrhea, and since it is because of some underlying pathology, so you need to treat that underlying disease. Now we know these OCPs, they are used as contraceptives. So let us summarize here what are the other uses of this OCPs, what are the advantages of OCPs basically. And we know they can be used as contraceptives. We have seen just now that they are used in the management of dysmenorrhea. Then they are the drug of choice even in cases of irregular menses. They regularize the menstrual cycle. Then they also are protective for ovarian cancer. We told that the more the number of ovulation, more injury to the ovaries, and it will lead to ovarian cancer. So if one is giving OCPs, then it is protective for ovarian cancer. Then they also provide protection in cases of endometrial cancer, endometrial hyperplasia, fibroids, endometriosis. Then they are also used for the management of excessive bleeding, that is menorrhagia. But one very important thing that you need to remember here is that when you are giving OCPs in a case of irregular menstrual cycle or in a case of excessive bleeding, that is menorrhagia, you should always first rule out the pelvic pathologies. Only then these OCPs should be prescribed. Because if there are any specific pelvic pathologies, they need to be treated before you give the OCPs. So in case of irregular menstrual cycle or menorrhagia, transvaginal sonography along with endometrial biopsy should always be done before you are prescribing anything. So this was all about the normal menstrual cycle. In our